All right, good evening, everyone. This is Shanieri Eze from Eze Family Health Center. Um, I am so excited. We're talking about this very and important topic surrounding race and health. We are doing part two to discuss discovering solutions to the racial disparities that we are experiencing here in the U.S. I'm joined tonight with a few panelists that were part of our part one that we had earlier this year. I have first Miss Delana Watkins. She is a board certified registered nurse and CEO of Transitional Care Consultants, a consulting firm providing patient advocacy and transitional management solutions. Her specialty is healthcare advocacy and preventive health services. We want to welcome Ms. Watkins to our webcast.
Hi, good evening, everyone. Glad to be here.
Awesome, awesome. And now we have Ms. Raquel Reed. She is a transformational therapist, life coach, and CEO of Empower Consulting. Her specialty is in mental health, emotional clarity, and support of the transformative process through understanding of self-perception. She's also founder and host of the Power Within webcast. Ms. Reed has also been featured on a multitude of platforms and is a best-selling author. Welcome, Raquel Reed.
Thank you.
Yes, yes. And last but not least, we have Dr. Giselle Martin. Dr. Martin is a doctor of public health and preventive medicine. She's a wellness coach and founder of Heal the Public, a collective to help address issues that affect minority communities. She has expertise in health policy and currently serves as a professor at Georgetown University. In addition, Dr. Martin is a certified health education specialist and has committed years to serving underserved minority communities to assist in improving health outcomes and disparity concerning healthcare access. We want to welcome Dr. Martin.
Hi, everyone.
All right. Well, thank you, ladies, again for joining me tonight. So this is a very heavy topic because we are talking about healthcare disparities. And during our first webcast, we had a chance to really kind of delve deep into what are the systemic issues surrounding the healthcare system here in the U.S., especially when it comes to race relations. We we got so in depth, in fact, that we went over an hour and we did not get a chance to really talk about the solutions and things that we can do to implement change. So this is why we, and also by popular demand, we have a part two, which is today's webcast. So we're going to get right into it, but I do want to kind of start with discussing some of these startling statistics. I know, and I don't know if any of our viewers, had seen the recent article on CNN, a recent newscast on CNN talking about the disparities in regards to newborn health. In particular, there was a study that was released stating that, it was basically a study from an observation of the outcomes from many different hospitals and what they found in regards to whether newborn care was different for white babies and Black babies. And what they found was very disheartening. Essentially, they found that Black newborn babies in the US are more likely to survive childbirth if they are cared for by Black doctors versus if they're cared for by white doctors. In fact, based on this study, Black babies are 3 times as likely to die under the care of white doctors versus Black doctors. So this is very problematic. And, again, really delving deep into what is the reason for such a disparity. A lot of us are aware of the differing mortality rate amongst, women, Black women who give birth. There's higher maternal deaths amongst Black women. Now we're seeing that it even affects the newborn babies. So I'd love to hear, what are your thoughts on, the fact that we are seeing this difference in, how for instance, a Black patient may be treated versus a white patient. And the issues of really implicit bias as a factor.
Well, I think we talked about this on the last episode as well. And so this study just really shows that it starts from the cradle, that the life of a Black person, individual, is not seen as important sometimes as the life of others. And that's not to say that that happens consistently across the board. And, you know, we're sure that there are some who are Caucasian that this would not apply to them. But the problem comes in when it seems to be more prevalent than not, that the life of a Black person doesn't hold as much weight. And what's really sad about that is because through history, I mean, this world was really built upon the sweat, blood, and the tears of African Americans in so many different ways, that we have contributed to what America is today. But yet, even moving from there economically, we are not as advantaged, right? So that's where so many different talks comes in, like, for example, reparations, right? To kind of equal that out. Mm-hmm. So this topic can take us so many different places. But at the end of the day, if in fact Black doctors take care of Black women who are birthing better, then somebody better get to recruiting some more Black doctors.
Mm-hmm. That is a good point. So statistics certainly have the number of African American doctors at about 4% of U.S. doctors are African American, yet we are 15% of the population. So yeah, that might be one of the key factors, is actually recruiting more African Americans in healthcare, and particularly primary care or medical providers in general. Dr. Giselle, I know in your line of work, you address the issues of healthcare access. That's another element that we find there's quite a disparity in regards to African Americans getting that same access to care. What do you feel are some ways that we can address this to improve this?
Well, I kind of want to go back to your first question before I.
Okay. Sure.
To be honest with you, so it's a great thing that policymakers and healthcare providers are finally turning their attention to the social determinants. I'm very pleased to see that. However, it's brought a lot of focus on the social and economic factors as to how we live, where we live, like demographic factors like race, our social economic factors like our education, income, housing, even transportation. And so that all of those SDOHs, however, is like where the focus has been. And those are external to the health environment generally. And they reflect a much broader sense of social factors that usually will kind of shield the healthcare system from direct accountability. And I think that that's been one of the biggest problems, is that kind of been hiding behind that. Whereas implicit bias, by contrast, which is what you asked about, is internally driven, and it has to be driven by the healthcare system, the healthcare delivery system specifically. And that is not what we've been observing. And that's, to me, that's what needs to really change in order to, to really address this issue at its root. Because if we can keep focusing on all of these external problems, and that's great, and it's awesome that we're addressing those things. But if we don't address it from the inside out, only but so much is going to be fixed. And these poor health outcomes that we have been, really paying attention to is not going to, it's just not going to make as big of a dent. So, you know, I have several different thoughts on how we can resolve that if you want to hear them, but I don't want to like completely abandon where you were trying to go with the conversation right now.
Well, I think let's stay on the topic. I think what you said is so relevant because in fact, you can try to change all these external factors, but the truth of the matter is it's the medical provider that is providing that service of healthcare. So we have to really start with the providers, addressing implicit bias, addressing how they are perceiving patients, whether they're consciously aware of it or not. Perceiving a patient by their race or their nationality or socioeconomic status. So, our discussion is about solutions. So certainly that's what we want to delve into. How do we improve this? Is it going to take cultural training or what can be done?
Absolutely. Dr. Giselle, and I just wanted to add this. I was actually going to say it at the end, but how you just framed that was something that I heard today. I was on a webcast earlier, and something that was said towards the very end was that in 20 states, racism is now a public health issue. They have raised that and put that on the agenda, that racism is a public health issue. Now, granted, the webcast that I was on was about the SDOH, right? And that was the broad topic. But like you said, those are external factors when really what you have to deal with is racism and implicit bias. So I just wanted to kind of put a pin in it and just say that I just heard that 20 states have now identified that racism is a public health issue.
Wow, that's really, it's a big thing to even hear that, because for so many years, I remember there was a press release maybe like 10 years ago, like HHS put out something that basically contradicted everything that you just said. And then they immediately redacted it like the next day because people were so outraged, like, are you serious right now? Clearly you don't live in Black or brown skin, obviously, or you never say that. So the fact that they put that out, I think
it's huge. And I'm hoping that that is like the elephant that now has eyes on it in the room. That it will, and I don't know what direction that will take things in, if it's just taking what we already know and not keep beating a dead horse, that we know about the social determinants of health, that we know all these things. What is it that we can do? Like Shinyeri said, some of the things that we'll obviously, as we continue on this discussion, talk about some of the solutions. And I mean, hard, fast solutions, not those that have been regurgitated and, shifted around a little bit and add some little fluffy foo-foo words to it to really just say the same things, right?
100%.
Yeah.
We need a very comprehensive approach to how we're doing this, and health equity. So like, people interchange health equity and health disparities, which is great. But one of the things that I've noticed, even within the healthcare system, is that more and more organizations are having chief equity officers, not just chief diversity officers. So chief equity officers are more strategic in thought. They're in the executive suite as well, but they have more of a cross-functional oversight of the healthcare delivery system's performance. And so they would work more like with people like me who work in healthcare quality. And so together we're looking at how the SDOHs and how the actual outcomes and also the experiences of the patients align together, versus the chief diversity officer who would focus more on like the internal recruiting, making sure there's diversity amongst staff, retention, creating inclusion programs. Those are the things. Those are important too, but diversity, inclusion, and diversity and equity, they're very similar, but they're also very different.
Right.
So that is something that I think is a win, and I'm glad to see more and more organizations doing that. I think we also need to do something to solve for clinician bias, not just necessarily talk about it, but like, okay, yeah, we all have biases, but
Mm-hmm.
we can't allow this to continue to limit the social um, interrelatability that we have with our patients and the community members. And we can't also let the economic factors limit us either. So we have to find a way to bring those together and then address clinician bias head on. I believe that there should be bias training both while you're in school and while you're on the job, because it's different once you actually get out there and start working versus when you're in school.
Right. So, say it louder for the people in the back, Dr. Giselle. Yes, come on. Let's speak it for what it really is. It's one thing to, kind of get that whole scenario of this is what we, again, as I just said, I was on a webcast earlier and we were talking about, the SDOHs, and we've all heard that at some point in our training, some point in our, clinical rotations. However, what does that look like in real life implementation and interventions? And I'm talking evidence-based, interventions as well, that we have to make sure that we are doing the work, not just talking about what it is that we feel is necessary. And I feel like we also, depending on where you are, it's going to be different in rural areas as it is in suburban and urban areas, how you do that. Like, we have to be very strategic in the different interventions that we hope and want to employ. And like you said, that whole, bias training of clinicians. Sometimes I feel like, if you ask the average person, right, and I'm talking about from the person who is as close to the care of the patient to those who may be very hands off, but still have some involvement in the patient care, they will all feel like they have no bias. But I promise you, if you actually sit down and really do the work that it takes, there are some biases that may not have just been revealed, or they were never asked, or they've never, kind of peeled back that layer to see that there's no bias. We all want to, deliver the care that we were trained to do. And we all want to do it in such a way that we feel that it's equal, that we're delivering, quality care, that, equitably to everyone. But I guarantee, and even for me, I've been in healthcare 32 years, and I can guarantee you that definitely early on, especially early on in my career, what I learned and what I instituted and what I did to intervene was probably two different things. And not knowing that there were some biases that I obviously, had. And then when I looked at that 30,000 foot view, I'm like, oh yeah, I definitely, had some implicit biases early on in my career. I know that I did. So I feel like if we start with in school, and then when we're mentoring and precepting, and then even those who have been in the healthcare industry for quite some time, when we do that, it will, I believe, change and help us to right the ship in the direction that we need to go in.
But you know what? I think that if we wait till school, we've waited too long. This needs to begin in the household and in our households. If parents were more aware, this is all about awareness. And so, as you said, we all have implicit biases, but when we talk about what's going on societally, nobody wants to do anything about this until there's some huge event that occurs. So it's not ingrained in our society. For example, look at all of the organizations now that are doing diversity training so that they can begin to have these conversations. I too offer that training, but it's like, oh, I think we need to do this. Why? So we can stay compliant. Is that the motive? Is that what it is? So we can stay compliant, not because you as the leader in the organization have been shaken to your core and realize that the level of awareness that you have need to change, because oil flows from the head down. So whatever organization it is, whether it's a college institution, a school, I mean, again, you can't wait for the schools to do it. And it's why so many people are sending their children to private schools now. If you're waiting for the public school system to do it, that's sure not going to happen. If you're depending on what college or institution or what program you're a part of, I went to Liberty University. It's like when you say certain college names, it means something. They are known for a viewpoint, right? They're known for that. So you as an individual have to look at that. But we have got to get this to a point that it's not what we do just because we got called out, but it's what we do because it's the right thing to do.
Mhm.
Right. Absolutely. I mean, it really does take some level of introspection. I think, unfortunately, and it's just natural human behavior that people think implicit bias and they go, well, I'm not a racist, or I'm not, they immediately become very defensive. And because they don't feel that applies to them, they won't do anything about it, not knowing that it, in fact, is something that they do, whether they're aware of it or not. So, you said it right there, Raquel. It really does start in the household. And, that's a whole other, element right there. But
Yeah.
it really does take even a societal shift to start realizing, hey, implicit bias affects our behavior, affects how we interact with other people. And in the case of, providing healthcare services, literally life or death. In the study that I referenced earlier, it's not to say that, white doctors aren't as, caring for Black babies and are allowing these Black babies to die. And I think a lot of people may have that, immediate response like this, but there is that element of, okay, why is this happening? Why is there that much of a difference in the outcome, the health outcome of these children, literally based on the differences in the race of the medical provider? It shouldn't be that way, So what do we do about that? Oh, go ahead, sorry.
It's okay. I agree. It shouldn't. And I agree very much with all of you. Raquel, what you said about starting earlier, I've long said, I actually wrote an article on this, that we need to start teaching our kids about health and finances. Why is it that the two most pivotal things that we experience in adulthood are not taught to us oftentimes until adulthood? And so 100% agree with that. I think that's it just needs to be in the schools, period. And they need licensed people, people who have, I'm not talking about a gym teacher, no offense to the gym teachers out there who teach health. I'm talking about someone who has a master's or a doctorate in public health, teaching our children about how to live long, healthy lives from the time they are children. And then to your point, Shingeri, about the kids. So something that about the babies, something that I read a while ago about, diversification in the medical field and everything. It was a study that they did. And one of the key elements that they observed was that most Black and brown people, it's not that they prefer, well, I'm not gonna say they prefer, but it's not that they are opposed to seeing providers who don't look like them. It's oftentimes the fact of they already come in there, they feel like they're going to be discriminated against or have some type of, they're going to feel the bias that their provider has. And you said something, is it that Black practitioners have different trainings or anything like that? I don't think that, but I do think that through life experience and through learned experience, that level of empathy comes across a little bit differently, which is why you don't see any disparity amongst the Black practitioners and you babies of all nationalities versus, well, not nationalities, but races, versus the other way around. And that's because many people, they just need to have better, not even just interpretation, because a lot of times interpretation, I feel, is on the back end where they might be like, oh, we'll call the language line. No, that needs to be real time. People should not feel like they're placed on the back burner. Well, my practitioner talked to me as broken communication as it possibly could have happened. No, you need to have something right then and there. And we need to stop having the conversation around the language lines and interpreters are an extra cost, because it's not. It is a very necessary component of this. But the implicit bias training that people need to have, I mean, it is pretty deep, because a lot of people can't communicate, for one. They're poor emotional, they don't relate. Their relatability factor is off. like really off. And I think that is a huge issue that leads to distrust in the Black community. And that is evidently observed in what you just shared and so many other things, like that empathy, we take it for granted. And I know, Raquel, you are the mental health professional of us here. Do you have anything to share about empathy? This is my hypothesis. I don't know.
Well, I think that some of us are empathic, period. Like spiritually empathic. We just are. And when you are that way, you have to learn how to hone, protect that energy. One of the things that I was thinking about as you were sharing was that regardless of what age a client of mine is, I've had a 3-year-old therapy client, cutest little boy you ever want to see, to an 80-something-year-old woman just recently. What I find as a common denominator, regardless, is that ability to express ourselves emotionally. Use words. So it is common for me when you come in my office to see a piece of paper with emoticons on it and words that express how we feel, because we live in a society that it is normal to numb how you feel. And we're so judgmental, because if you use drugs or alcohol, oh my God, you are numbing your feelings. But if you eat to numb your feelings, too much sex, or some people are probably saying, how do you have too much sex, Raquel? But there's a condition for that. But there's all of these ways that we numb. And so from a 3-year-old to an 80, 90-year-old, we don't know how to share how we feel about something. We don't know how to create boundaries, healthy boundaries, with our words and with our actions. Instead, we have huge walls that we erect. Offense number 1 came, we put the stake in the ground. Offense number 2 came, that hurt a little bit too much. And you know what? I'm not going to let you keep hurting me. But what do? And especially as women, we file that offense away. We don't forget that offense. And so many things are building up on the inside of us. Someone said just recently, many of you offer your services to women that you think need them. But why don't you, or who don't have a lot of money maybe. They said, but why don't you offer those same services to affluent women? Because affluent women have the same problems. And I said, that's so true. But many people are, they don't know the language. They don't know the verbiage. They don't know how to say, oh, you're a successful woman, but you're lacking confidence. Look at what you've accomplished. You've built this, you've done this, you've done that. But you lack confidence. Oh, I can't say that to her. Right? But it's true. So we all have those insecurities. We all need support. And we all have to use our voice. I'm going to tell you one thing that a lot of people that I work with don't realize. If you have a lot of issues with your throat, consider that you're also having trouble with speaking the truth or your truth. Okay, we can't go into that right now, but I'm telling you, there is definitely a connection. Speaking your truth. I didn't say speak the truth. I said speaking yours. Okay.
So coming back, really, Raquel, you hit it right on the head. Being able to express yourself, being able to, as a person communicating or receiving information from another person, being able to have that level of empathy. And as Giselle, you had mentioned earlier, how often, African Americans, we are almost expected to be discriminated against. I had seen this post, I think it was a doctor on Twitter who really had this kind of epiphany when I think she was a critical care doctor, and a young African-American man got in a car accident, and he was on life support. And she was an Asian woman, I believe. He was on life support, and the family pulled her aside and told her, he's a good man, he has a family, he went to this school and got this degree. I mean, basically presented his entire resume as if to say, he's worthy to live.
Mm-hmm.
He's a good guy. And she was shocked because she was like, the family felt the need to tell her, this man is a decent man, so that they can have some hope that she would take that in and give him better care.
Yeah.
So that is the sad state of what it is, where that implicit bias comes in, that we as African Americans often have to feel like we have to prove our worthiness to get the similar care that, quite honestly, a Caucasian patient may not necessarily need to do. So,
but you know what? We're always doing. We've always done that. Like
and we don't even realize it, I think, sometimes.
Right.
Yeah. And when I was growing up, I remember at some point my mom was sick, and it's the reason why I'm a mental health therapist today. So just a part of how I was groomed into this. But I remember going to social services in Winston-Salem to get some help. My mom, one of the things, even though we grew up in poverty, my mom taught me there's never any reason not to look good. Period in the story. And so we would go down to social services to get help. And I'm gonna be honest with you, it didn't matter if it was a Black person or a white person. The treatment was pretty much the same down at social services. And I remember literally going in there time after time, and because we were dressed well, we didn't get the help that we needed.
Wow.
We looked too good. You don't look impoverished. You don't look like you need anything.
Yeah.
And so the resilient person that's before you today is because of stuff like that. Because you learn that everybody else is not going to do it for you. So you have to take care of yourself. I started working at 14 years old. I had no choice but to do so.
Yeah.
Because I had to come out of my situation, and I knew that, these experiences happened too many times where I literally had to become the mouthpiece for my mother and go in, help and explain our situation. And I remember even thinking that I needed to lie to get the help.
Yeah.
The Raquel, oh, sorry.
Go ahead.
You just made me think of even people, like as it relates to healthcare, sharing your story, how many people realize they're being discriminated against in healthcare, but because they know they don't have that many options, because let's say they're on Medicaid or something else, they just take it just to get the services and just get through it. But like the trauma that causes long term is, it's just sad. And look at what it's been doing to the community. I mean, and you wonder why Black people don't trust healthcare providers a lot of the time.
I was just getting ready to say that, Dr. Giselle. I was just going to say, unfortunately, it's scenarios like that and/or interactions like that form how we view health, whether it's healthcare, whether it's social services, or whatever resources that we feel that we may need. It's because of the historical, like you said, Raquel, because you grew up. And so that's something that's just kind of etched in your mind. It's because of those type of interactions, unfortunately, that formulate, again, how we see, the healthcare delivery system and or various resources and support systems that should be there for us to help us in, those situations.
Yeah. And just sorry.
Go ahead.
Provide, I guess, a solution, because I know we're trying to provide solutions, not continue to harp on the issues. I think a really good solution for this, especially like Tuskegee, for instance, almost everybody, young and old, knows about Tuskegee. If you ask any Black person as it pertains to their healthcare, a lot of times if they don't know about Tuskegee, they know about something. They know about discrimination. But I think that one thing that providers can do is to actually address the elephant in the room. I mean, to date, I don't think we've ever heard. I mean, the HHS has put like out these little powdery articles about Tuskegee, but it was never a formal apology or even an acknowledgement that it's like, you know what, we realize that as a community, this was done to you. And so naturally you distrust us. We want to earn your trust again. When have you heard that type of narrative come from HHS or any major health care facility anywhere? Like, I really feel like we need to address these reasons why people don't trust practitioners. The reasons why people think that many medical providers, they're just out for the money. They care about profit. They prescribe all kinds of random diagnoses and ICD-10 codes or whatever that sometimes might not even be the case. Or they might have had a misdiagnosis and received unnecessary treatment that way. So there's a lot of different things, a lot of different experiences that people have had. And then you look at research, you have the nerve to ask people to be a participant in research.
Yeah, I was just going to say the same thing. Yeah.
I mean, that's even recently with the trials that they're doing for COVID-19. They recently revealed they've been having a extremely difficult time recruiting African-American volunteers for the vaccine. And despite our population being the most affected by it, by this new disease state, people are not lining up to volunteer as part of a trial. And, you know, again, looking at that historical context to it, I mean, it makes sense that that would be the case. Now, you know, we've kind of explored the implicit bias, you know, coming from the healthcare provider, and now kind of shifting from that to the patient experience. Racism, you know, living as an African American in this country, racism is something that we experience even from a small age. So there's kind of understanding what are the mental and psychological effects that come into play. When you experience racism, this is kind of a part of, you know, your understanding and how you perceive things and how you perceive the world is viewing you, how that affects us. And, you know, especially when it comes to, you know, stress, quite frankly, which is something we all experience, but stress that is linked to racism in particular, which, you know, Giselle, we were talking about this the other day on the Heal the Public podcast in regards to how that has, even the long-term and prolonged stress has a genetic impact on us, and that can even affect generations onward. You know, speaking of the subject of epigenetics, don't want to go into that pile, but really kind of exploring how the stress of racism affects us, and how it can actually adversely affect our health. Being that, as Delana had mentioned earlier, racism is considered a public health crisis. Anyone want to take that on?
Woo.
So racism is stress. How do we address this? What can we do in our community to help improve this?
Well, you know what's funny? As you were speaking, I don't know about anybody else, but I didn't experience racism until I moved to North Carolina. And I was 13. I didn't, if I experienced it, I don't think I knew about it. When I got to North Carolina, it was pretty clear that there was something not so right with me, and that some people had a problem with that. Just not even just being Black, but being a Yankee, you know? So all of that was compacted. It's like, you're so different. You're very different. You're Black. We don't like that. You speak differently. You talk really fast. So I think you're trying to get over on me. It was just a crash course in something's wrong with you, And so that shaking at the core, not to mention that was around the time that I'm also sharing that experience with social service. That was in North Carolina. That wasn't in New Jersey. And so our experience, I think, with social services there was just really different. But as it relates to stress can literally fracture your brain. Like you talked about epigenetics. Now that's taking it deep, and we have to learn and understand that as well. We must take the time. We're spending so much time watching things that won't help us and leave a legacy. We're Martin, whatever it is that you watch on TV. Like I work with a lot of young kids, and they tell me about these different games, Roblox, and all this stuff, and writing in code, and all the things that they're doing. And it's like, really? And your parents just let you sit and do that pretty much all day because the parents are very distracted. And so, and many just trying to survive, right? So we're not thriving, but because of the stress, the impact of the implicit bias, then we're just really just trying to make it from one day to the next. And guess what? And we're teaching our children that that's what you got to do. Just make it from one day to the next. Or how about this? Just get home. Leave today because I'm worried, but I just need you to just make it home because you're Black. So it's just so much that as a parent that you're worried about, but you don't know what's going on in that young person's head about what it is to be young and Black in America today. You have no idea, because when we're so young, we're innocent. We're tainted at some point by other people's view of whether this world is safe for us or not. Take a 3-year-old, a 4-year-old. They don't know anything about this, and their imagination is just thriving. But we as adults are stuck in this rut, this rat race of just trying to make it. And so what has to happen is we have got to steal away. We've got to get to a place where, one, we're the fishermen. We're providing for ourselves and our families so that we can be at the head of our families and we're in control. With so many families just feel out of control, like their lives are in the hands of the next politician. Their life is in the hands of, just all these other people, but not them. And so one of the things that I suggest, because Black people, we also know, don't really like to go see mental health therapists because there's so much stigma around doing so. If you do so, then that means you're crazy, or all these, or this is bigger than crazy. You're weak. So, why do you need to go sit and talk to somebody? That means you're really weak if you need to go and do that. And so as we continue to have these conversations and move that stigma, one of the things that I help introduce my clients to is things like mindfulness. Like a lot of us are faithful people. So even if you're not, then the word mindfulness seems to resonate with people as just a way to get time to yourself, to calm yourself down. So one of the resources that I recommend is an app, since we're all on the go so much, is the Calm app. The Calm app really gives you, I actually really love that app. It just gives you a breakaway. And if your day is so busy that you can't take 10 minutes, then I would guarantee you that you're busy doing much of nothing. Because some people, remember I talked about numbing earlier, some people numb with work. And so they're unproductive. That's why I love working with really powerful women. Women who believe that they're powerful, right? They think to some extent that they're powerful. But if you're so powerful, why can't you give yourself 10 minutes?
Right. That's powerful.
Because that's where that creativity is harnessed. That's where you're recharged. So 10 minutes a day, take some time to yourself. Sometimes I leave from my office and I just go outside on the back porch. Black people need vitamin D too. Go get you some vitamin D. How about there's another online resource called Headspace. And if any mental health professionals are watching this webcast on the replay, then you should know that they're offering it free for mental health professionals because they understand the work that is ahead of us because of COVID, and they wanted to make sure that we were given ourselves some headspace. So that's another one that just really simply teaches you how to breathe. And what's really important about breathing is if you believe that we didn't get here because of the Big Bang Theory, but we got here because of a creator that blew life into us through the breath, then your breath is really important. And when you go on Headspace, that's one of the things that they're going to teach you is how to use the breath. There is life in the breath. If you're not breathing, you're dead. So I need you to just take out some time for that. So that's 2 resources. And then the third resource I want to give you is essential oils. So I keep essential oils right by me all the time. So here's one. I don't have to reach far to get an oil that's going to help me with something. So this one helps me with clarity. I'm called the Clarity Coach. Why wouldn't I have some support to make sure that I keep it on 10, right? So when I'm feeling a little bogged down and I took a little break to give myself a breath, I put this little oil on, put it on now for you so you can see I'm not just talking about it, I'm doing about it. And I'm telling you, this is something God created that blesses us that you could use to support you. Whether it's sleep issues, you don't have to take medicine all the time. Sometimes try that least restrictive thing that gets you the support that you need before you go straight to some kind of chemical something that gets you the help. So there's a lot of help. So all the links are in there for you, but you've got to listen. If you don't give it to yourself, you can't blame anybody else. This stress is triggering me and I'm so mad. You're still responsible for that. You're the one that has to transform that. So when I was a child and we were treated unfairly, I did learn to put some walls up, but I also learned how to navigate and take them down. So because every practitioner, every social worker didn't judge me for wearing nice clothes. So I had to, that was my work. That was something that I needed to do. So this is another self-help tip. Just ask, what's the lesson? Because everything has a lesson in it. Everything.
Absolutely.
Yes. So much of what you said, just girl, I felt like I just went to church for a second.
You better say so.
Yeah, I mean, it comes down to thriving versus just surviving, right? Essentially. So understanding that, and studies have shown that 80% of chronic disease is linked to stress. Prolonged and stress, whether this is stress that you're aware of or just kind of right underneath the current. It's something that absolutely needs to be addressed. I know, Delana, in your experience dealing with chronic disease and especially the impact on the African American community, I mean, this is the statistics are not in our favor. Higher levels of mortality, higher levels of heart disease, higher levels of diabetes. So addressing, the issue of chronic disease that's within the African American community, and how can we combat that from a cultural perspective too? Not just talking about, eat well and exercise. Well, everyone knows that.
Everybody knows that. Yeah. There's only so many ways.
What is a more effective approach to really addressing this issue?
Right. And I'm so glad you said that, because there's only so many ways you could slice that pie about, eating right and exercising. What exactly does that mean? And I think just kind of, when I was thinking through my mind, how can I put this in such a way that it definitely provides a solution, that it allows us to look at something that's tangible, something that we can actually do, right? Instead of just talking about. And who remembers, and Rochelle, you brought this back to me when you talked about going to social services. When I remember growing up that we had community health centers. Do you remember being able, and either that or my grandmother having her physician that came to the home to see her, right? There were house doctors, house calls, or you felt like you were part of a community. And I think part of the solution is that we need to identify and create community health centers, community health workers, and healthcare providers that look like us, that speak like us, that understand and can empathize and can relate to our experiences. And if possible, have them be part of the community, mean they live and work right there in the community. And why I say that is because when you say to someone who, as Dr. Giselle talked about earlier, is dealing with those social determinants of health, and you're telling them, oh, eat healthier, eat more fruits and vegetables, exercise more, stop smoking. You know, when we go down this whole litany of lists of things that we know that they should do to impact and help with their chronic illnesses, but we don't realize that they don't have access to certain things, that they are unaware of the impact of obesity or being overweight, how, again, it's culturally acceptable for them to have some meat on their bones, right? Mm-hmm. When they don't understand that lingo, that language, and or the cultural acceptance of that, then they can't help and or teach them from that point of view. So I think going back to having community health centers is one way for us to do that. And I'm talking about make sure we have community health workers and healthcare providers that are culturally competent working in those centers. It's almost going back to a whole boots on the ground approach. And then when you look at that, it's community health improvement navigators. Now that is the key. You really want to talk about, you know, kicking it up a notch and doing something for us in health disparities and in marginalized areas. Put community health improvement navigators in those hospitals that are like the 911 centers for those communities. Have them identify the individuals that are at risk and then send those community health improvement navigators to their home. Give them the education that they need, again, at their level, speaking their language and talking about their experiences. And at that time, they can assess what they don't have access to, what they need, where they need help. What does diabetes translate to them? Is it sugar? And when they say, oh, I have the sugar and my grandmother had the sugar, and then all I can equate with that is you're either on dialysis or you're going to die. So for them, diabetes is a 3Ds. You have diabetes, you die, or you're on dialysis. And so because of that, they're typically fearful of what that means. And so they don't want to oftentimes embrace it and empower themselves over the illness, the chronic illness. So I think one of the resources that I shared was, I think it's Black Doctors USA, is one thing that we can do as we're trying to, on a national level, get policies in place so that we can have community health centers or navigators and community health workers in these marginalized areas, because they're out there. So what I'm talking about isn't far-fetched. There are these, you know, people that exist. They're just not deployed with boots on the ground to the areas that need them. So I think just to answer your question, to help us, because there's only so many ways, you know, Shanieri, that you can say, you know, eat right, exercise, you know, don't smoke. I mean, we all know these things, but we're not having people come into our communities and see what that means for us, you know, sort of that, you know, cultural acceptance of where we are and looking at the social determinants of health, and then what can I do about it?
Right.
Can I add to that? Yeah, I would definitely agree with you. And I would say that there are a number of collaboratives and coalitions, community collaboratives and coalitions around the country. Oftentimes these are overlooked. They're very grassroots, but they're doing some good work.
Yeah.
I would really encourage the people who are giving money to this cause to look at some of the work that's already been done. A lot of these coalitions have community ambassadors, people who are embedded, have been in that community for a long time. They're trusted. We also need to do more work around, you mentioned community health centers, getting the federally qualifications, becoming an FQHC, so that you can get the extra federal funds and help to be, so we know, like, mean, you have medical deserts where people have to commute all the way across town to get to a provider.
Exactly.
But if we had more FQHCs, we could have these clinics in different communities so people don't have to travel. We should be going to them.
Right.
So partnering with co-host pop-up clinics. If you are near a medical school like what Howard does, they have a lot of different resources. And so a lot of what we need to do is not necessarily us inventing something. It's just getting out of our silos and working together.
Absolutely.
Absolutely. I think, you know, something that's unique to our, the African-American population, there's certain elements of our community that are accepted or embraced. For instance, you know, there are higher rates of obesity, unfortunately, in the African-American community. And a part of that is, you know, kind of socially and culturally acceptable to be
absolutely.
you know? So, you know, there's that element. But on the flip side of that, understanding that, you know, for instance, a scale, I guess, that a lot of medical providers use is what we call the BMI, which is the body mass scale. And a lot of providers use that as a means to really, you know, according to kind of a height to weight ratio, what a patient should be, what weight they should be in particular. So the thing is, the origin of this particular type of model or scale was initially the bodies of white young men, a majority. So, you know, how can you then try to extrapolate this particular scale based on a certain population only? So, you know, a vast majority of people would be overweight, obese, and it may not necessarily fit our particular population. So going back and addressing, you know, what are the elements, particular in our community, that may be adversely affecting us? Again, kind of embracing being a little thicker, right? Versus, you know, understanding that, you know, health and wellness is about weight management and eating healthy and, you know, not necessarily eating soul food all the time, you know, not to say that everybody does, but what are some ways that we can kind of incorporate more of a healthier lifestyle, again, that's unique in addressing our community? You know, I've seen efforts in, for instance, creating vegan soul food. You see these restaurants popping up everywhere. I know, Giselle, I think you have a cookbook coming out on a vegan keto soul food, you know, type of dietary regimen. So what are some ways, again, unique to our community, that we can address these issues?
Well, I think it is very important for us to have representation. And, you know, I say this as someone who has a nutrition business. I mean, we have to get to the point where we have representation in our communities and people who have tailored these health practices to the specific communities. Most of the health practices that are pushed on different communities, or even the recipes, like you mentioned, Shingeri, they're not culturally relevant. So we need representation, and we need cultural representation in the messaging that is different.
Sorry, that's me. Go ahead.
By the way,
Thumbs up.
Sorry.
I mean, even as far as the colors that are used, there are different colors in the messaging that in the branding that's used for different populations, and we have not seen that. So, I mean, I also feel like some of these companies have kind of preyed on, I hate using the term prey because it sounds so horrible, but preyed on minorities that they know will eat certain foods, and they purposely market to them using colors and messaging that they know will appeal to them. So on the flip side, we need to be very, very intentional also about doing the same thing and being able to just be relatable and speak the language of the target demographic.
Dr.
Right.
Giselle, you're after my heart. I love it. You said everything that I was just about to say. Again, we spoke about this before but just in a different way. And I love the way you put it, honestly. I teach a lot of my clients about how they spend millions on strategic marketing and to a specific demographic population. Front label marketing is huge because we don't do the simple act of picking something up and reading the back part, which is where all the goodies is contained, which is the ingredients and the nutritional implications of what it is that we're about to consume, right? We are, like you said, it's very color specific, as well as the wording that's used that speaks directly to a specific demographic of folks. And so unfortunately, that is why oftentimes when we think that we're doing ourselves a service of eating better, oh, I bought this and it doesn't have X or it doesn't have Y and it's no sugar added and it's this is that, my clients are rattling off all these things that they think is supposed to be a better selection or a healthier selection for them, only for me to dash their hopes by asking them to turn it around and read the first 3 ingredients. So unfortunately, it's very much so that we have to, change the narrative even about the things that we consider to be healthy, and again, Dr. Giselle, as you said, making sure that we have more representation about what healthy looks like and what we should be consuming as it relates to the foods that we, choose to cook and prepare. And even the way we prepare them, just simply changing how we prepare the things that we culturally love can shift it from being unhealthy to being healthy.
And still tastes good.
Yeah, and still taste good.
Yes. I think also with even body representation, sometimes people have this view of what healthy is, but that's not necessarily it all the time. Everybody's not going to be a bodybuilder. Let's be right. That's not the picture perfect of health either. And America does a really great job of desensitizing us to that. But even tips, like you mentioned the nutrition labels, I teach my clients, if it has more than 10 ingredients and 10 ingredients that you can't even read, that's probably a food you should not ever put in your body. Not ever.
Absolutely.
So just teaching people making nutrition simple, because our country has done a great job of overcomplicating one of the most beautiful things that there is. Nutrition is art. It's fun.
Art, yes. And we've, like you said, complicated it. I love the way you put that. Absolutely. Yeah.
We should collaborate up with this.
Yes. I see it.
That sounds like a good idea. Yes. Well, ladies, this has been an amazing conversation. And, certainly I forgot to mention earlier, if anyone in our audience has questions, they can certainly, shoot that out in the chat window there. If we're not able to answer it during our webcast, we have just a few minutes left. We'll definitely be able to give you some resources there as well. Now, I would love for each of you to, we definitely touched upon a lot of things. We kind of offered some solutions and some ideas and things that we can do as individuals and as communities to address these racial issues in relation to healthcare and wellness. I'd love to just kind of hear from each of you ladies, what projects and things that you have going on, what resources you'd like to share. So we're going to kind of start clockwise here. Delana, we can start with you.
Absolutely. So again, thank you so much, Shanieri, for having me for part 2 of the race and health discussion. So I am always working on a whole bunch of projects as usual, but one that I'm working on in particular right now deals with a sugarless workshop. So it was a program that I initially offered. And now since we're dealing with people being home and less activity prone, I'm getting inundated with a lot of people trying to deal with pandemic pounds. So I've created a sugarless workshop. Instead of doing the 45-day program, I condensed it into a sugarless workshop where we go over some of the things that Dr. Giselle and I just talked about, which teaches you the foods that you should be eating, those that you should be avoiding, how to read labels, and things of that nature. So you can find out more information about that particular workshop at DelenaWatkins.com under the products section on my website. The other thing that I'm also working on is a chronic care management program with that. And you can find out more information about that on transitionalcareconsultants.com. So that's almost ready to roll out. There's a few more things that we're working on as far as the CRM to be able to work with healthcare providers on the chronic care management. And a lot of what we shared this evening will also help to employ or deploy, I should say, some solutions in the area of helping individuals who do have chronic illnesses and what things that they can do from a patient advocacy standpoint.
Awesome. Thank you so much, Delana. You've always got a ton of things going on.
I know.
Yes, I love it. And Dr. Martin?
Yeah, so I am finishing, finally. Well, I have finished my books. I'm releasing 2 books, and I'm so excited. Oh my goodness, guys. I don't know if anybody has ever written a book before, but it's a process. So I've written, actually, I'm building an entire platform. So it's a cookbook, and then it is an actual book, like a weight loss book, which is why I'm like, Delana, you are doing like amazing things over there, girl. I aspire.
Thank you.
My book is called Intermittent Keto. It's called The Fastest Way to Lose and Maintain Your Weight. I got the idea because I have a couple of clients who are like inundated and super fascinated with the ketogenic diet. Right. However, keto is not long-term sustainable. I don't care what anybody says.
No.
If you plan on having
say it louder for the people in the back. Come on, Dr. Giselle. Come on.
It's not. It's not. So I did a lot of studying over the past couple of years, specifically on ketogenic principles. And so I adopted some of those principles and then paired it with intermittent fasting. And so, which intermittent fasting is a much more sustainable mechanism to maintain your weight. And it has so many other health benefits that I'm not going to get into right now. So, and it's literally a step-by-step program. Like, it's very, very easy. I have used it myself to lose over 40 pounds. And then I'm also creating a cookbook, which, well, I have created a cookbook. It's just going through the editing process now. It's a companion guide to the book, and it's called Keto-ish, a cultural exploration of high-protein, plant-based soul food. And so it fits into like all of the macros, all of the things that you like to eat, but you can have your black-eyed pea fritters and your sweet potato pancakes and whatever else you want to eat. It's just made, like you said, Delana, it's just made differently so that it's healthy. And, I even have like food substitutions, all kinds of different things in there. So if you want to make it vegan versus vegan, you want, like even sweeteners. So we go over all of that stuff. So that I'm also creating an entire wellness program that will be, my app should be out probably in October. So I'm creating an app. I am an exercise physiologist as well. So that fitness was actually my career before public health. So creating like women who want to get a bigger booty, like you want 6-pack abs, like all of these different things. So different programs for different folks with different strokes. So anyway, you can find more about me on Instagram, mostly at Dr. Jazzy Fit. And also the podcast, I have to.
Yes, you can't forget the podcast.
Our podcast with Shingeri is one of the co-hosts, launched on Monday. It's called Crucial Conversations.
Oh, yay!
And it is, honestly, this is my ministry. Like, this is something that I feel like God birthed in me several years ago, but I was not confident enough to act on it. And so the fact that it actually is a thing now, and it's like I can search for it and it pops up. And it's like, oh my gosh. But anyway, it's called Crucial Conversations to Heal the Black Community. And it's it's very much similar to what we're talking about tonight, but we talk about all components of health, but on a very practical level. So things like we had a judge where we talked about the incarceration crisis. We've talked about interracial dating and why people have these varying views within the Black community as it pertains to that, and how we need to move forward, or ways that we can move forward as a community to unify on some of these topics. And if we don't see eye to eye, to at least respect the view and where the views come from. Because we don't have to be all the same people, but we need to find a way to be unified as a community to help address these health outcomes. So that's what I'm working on.
Awesome. Great job. Oh, you are amazing. Oh, I can't wait. I want my signed copy of that book, by the way.
Yeah, me too.
I got you.
Press.
All these Black girl magics right here in front of me.
Yeah.
I got one.
I love it.
Awesome. So Raquel, I know you are Miss Author, podcaster. You've got it all going on, Raquel. So tell us a little bit about what you're doing.
Well, actually, what I'm doing is trying to be an example of what I'm preaching at this point. So I've slowed down. I think that many of us have really gotten to where we are because of where we have this mode that we have to keep accomplishing things. Instead of being who we are, we become our accomplishments. And so I'm actually practicing just being. And so I already put out 2 books in January 29th, The Black Butterfly's Journey Towards Clarity, Reveal, Renew, Reignite. And when you write a book, you live it, right? So I think that I'm still living in it, and some new things are coming out of it, but I think they require stillness in order to come. And I want to help Black women especially, but all women, with stillness and learning how to be still, and that we are enough. And so that's what I'm doing. So if you want to get the books, you just do bit.ly/author. bit.ly/RRR author. And the podcast, yes, we're still doing the podcast weekly on Mondays at 12 noon. It's called The Power Within. And so I think this Monday coming, the episode is called We Were Created to Create. And I'm very excited about that. My podcast usually is about 20 minutes, 30-minute shows, and just giving you inspiration. We laugh, we have a good time, not too deep, but we get the job done just to get you inspired to creating and doing what you believe that God has called you to do. And I have a program named after the book called Reveal, Renew, Reignite. It's my adult program for women in coaching them. And again, those high-powered women that are just so busy, I want to help you. And so that program, we're going to be putting out some free value ads so that you can really get to see what I do. And I think we're going to actually do some live coaching for those who are daring enough to do that with me. There will be no practice for that because we don't need it. We really have just got to come comfortable with just being. And until we see other Black women doing that, we're going to struggle. I was talking to someone earlier today. We were talking about vulnerability, and they said to me, I'm leasing my vulnerability. And I said, I don't know when I'm going to use that, but that's going to get used because I never heard it put like that. And so remember, I talked about the walls and the boundaries, the difference between them. And sometimes we go into relationships, we say we're committed, but we're not really committed because we're afraid to be vulnerable in those relationships. We've been hurt so many times before. And I think my whole life's mission is really to help people transform pain into purpose, because I believe it really does have a purpose. And when we all figure that out for ourselves as individuals, then corporately we can come together and do something really powerful. So I'm working on Raquel as an individual so that when those corporate collaborations come, I'm ready to help and I'm effective. I'm not dragging things down, but I'm helping to lift things up.
Awesome. Wow, this is amazing. I am so glad you ladies were able to join us again tonight for our Race and Health webcast, Discovering Solutions. This when we released this back in, it was about a month ago. We had over, I think, 3,000 views. I think after the second replay or second day after our webcast, and I think this has been just a powerful platform. I'm so glad that we can get these minds, these different perspectives to talk about the issues that are affecting our community. So again, I thank you, Delana, Giselle, Raquel, for joining me tonight. Who knows if it's going to be by popular demand? We may have a part 3. I would love to have you ladies come back again if we do get called to do a part 3. And I thank the audience for coming, for viewing tonight, and hopefully you were able to get some good information. You can check out the chat, the chat box on the side with all the resources. There's information on how to get in touch with Delana, Giselle, and Raquel, as well as their platforms, their website, and their information. So until next time, everyone, thank you. Good night, ladies.
Good night.
Good night, everyone.
Bye-bye.